Good morning, everybody. Welcome to our webinar this morning on the NHI Bill, or now the Act. It's now just before 10, so we're going to wait 2 or 3 minutes for the numbers to join us. We have had an incredible response to this webinar, so there will be some people that will be joining us via YouTube as well. I just want to give them a minute or two to link in to our webinar this morning. So just bear with me for a minute or two, and then we will start at 10 o'clock sharp. Once again, good morning to everybody. It's now 1 minute to 10. We are seeing a number of people still joining us. So I'd like to welcome you all in the meantime, and please just bear with us for another minute or two until we have everybody on board, and then we'll start our presentation this morning. Right, it's now 10 o'clock. Ladies and gentlemen, I'd like to welcome you all to our webinar this morning. I think it's a very topical discussion point. I think this has probably created more anxiety than the election, which is taking place next week. And I thought it was important for us to share some of thoughts and ideas with you regarding the NHI Bill, which, as you know, since last week is now an act, since the president has signed it into law. So welcome to everybody. For those of you who haven't met, my name is Gary Feldman, and I head up the NMG Healthcare Consulting Business Unit. And I'm glad to share some thoughts with you this morning regarding the NHI. As I mentioned, a very topical discussion point. The media has been covered with it in the last 10 days. And ultimately, it's important that we share some thoughts and ideas with you to alleviate some of the anxiety that people are experiencing, and also the concerns that people may have. So please, if you do have any questions throughout the presentation, please post them in the Q&A, and we will try and address them at the end of the session. If we don't get to them, we will do a summary of all the questions and answers, and we'll distribute that to everybody as well post the session. We'll also hopefully be having another one of these sessions on Monday due to the demand that we've experienced from our clients. So if you share this with your colleagues, friends, there will be another invite going out in the next couple of hours, hopefully later today. Ladies and gentlemen, the agenda today is really around NHI. So what is NHI in a nutshell? The implementation of the National Health Insurance Bill, and then the way forward, what you should do and what you shouldn't do. I think it's important that we basically share that with you, because I've had numerous questions from various organizations and individuals saying, what do I do now? Do I cancel my medical scheme? Do I cancel my gap cover, et cetera, et cetera? So I want to just share some of those thoughts and ideas with you that we have basically done research, spoken to legislators, legal people, and also providers in the market. So if we start off with the NHI in a nutshell, I think it's important to basically put the position up front. We all do support a universal healthcare. I think it's imperative that every South African citizen, no matter if the person can afford it or not, has access to quality healthcare. And therefore, a universal healthcare solution is imperative. The fact that the NHI Act as it stands now is not feasible is the question that we want to address. I think there are a number of issues that we need to look at that need to be addressed. And I think first and foremost, the two key areas is really the funding of the NHI Act and the benefit structure. But ultimately, the goal of universal healthcare is something that we are not questioning for 1 minute. So if we look at the basically process and the timeline that has been followed to date and going forward, I think it started way back in 1998 with the Medical Schemes Act, which basically gave a clear definition of how the private healthcare environment gets regulated, and every private healthcare medical scheme has to follow the Medical Schemes Act. Providers, and when I talk about providers, it's not only medical schemes, but doctors, hospitals, etc., have to abide by what the Medical Scheme Act says and regulates. Subsequent to that, there's been a number of different documents being released. People have engaged. I know it was in the Polokwane, the ANC Lekgotla in, I think it was 2007, where the NHI really came to the fore. And ultimately, in 2018, they basically asked for written comments. And through industry bodies, we have and numerous other organizations, providers, medical schemes, regulators have all given input into this. And basically, as recently as May in 2023, the bill was approved by a Parliamentary Portfolio Committee. It went through to the National Assembly, then went to the Council of Provinces. And even at that late stage, we still gave input to why the NHI bill in its current structure is not feasible and not implementable. But as recently as May this year, the President found it necessary to sign it into law, and it then became an act. And that was now been published in the Gazette. And what is the way forward? Now, the constitutionality of this bill and act will be challenged. And if we look at the numerous reasons it will be challenged, but one of the main reasons why it will be challenged is all the submissions that were made, and providers and regulators submitted 600-page documents which were almost ignored in totality. So over this period of time of consultation, none of the inputs were really taken into consideration, and none of the deficiencies were actually addressed and changed in the bill as it was presented to the President for signature. So now, therefore, there's going to be a long change, and people are going to consult, and legal challenges will be raised by basically to ensuring that the bill gets embedded in a way that is, number one, feasible, and number two, affordable and sustainable. So this is going to take a long period of time. And during that period of time, it's important that people retain their medical scheme benefits and structures as they currently are. If we look at the healthcare environment in South Africa, we've currently got the public healthcare environment and we've got the private healthcare environment. Now, if you look at those two environments, what is spent there? So the public sector, the 240 billion rand that is spent in the private sector, is majority is the contributions that you and I pay to a medical scheme. So that comes and is paid with after-tax money. The public sector is spent 259 billion approximately, and that is also tax that you and I contribute to the government coffers via our payroll taxes, VAT, etc., etc. Now, if we look at basically the number of people that are reliant on these expenditures, there are approximately 9 million people that are reliant on or make use of private sector, so that's 14% of the population, and there are 55 million that rely on public sector private healthcare or public sector healthcare, and that's 86% of the population. So you're going to look at the average expenditure per year. It's a simple arithmetic there. It's approximately 27 million spent per person in the private sector and 4,000 in the public sector. And that is the difference where we see the constitutionality might be challenged as well. If you're going to look at section 27 of the Constitution, it quite clearly says that if you want to take something away from a person, the right to insure, you want to replace it with something equal to or better than what the current benefit that the person has in his personal and private capacity. So there's no ways that you can replace something that is costing on average 27,000 Rand per year with something that's costing 4,000 Rand per year. And that is where the first element is going to be challenged from the constitutionality of the NHI Act. The other point is that was raised as well was, if you look at the number of healthcare workers, in the private sector, there are 360,000 workers versus 243,000 in the public sector. Once again, it's really 24 members per worker versus 209. So there again, the service levels cannot be compared if you look at the number of people that are going to service this sector versus also the hospitals. I mean, so the hospital numbers also changed dramatically, and we know that the public hospitals, unfortunately, in this stage, are in a state of total disarray. So ultimately, what is required is we need 500 billion that is currently spent on healthcare in South Africa. And as I said, the bulk of that is with after-tax money, both in the public sector, money that the government raises via taxes, and the private sector is predominantly medical schemes contributions. Now, once the NHI is implemented, what are the three options that you are going to have? So your medical scheme, and that has been clearly stated that a medical scheme will be available to provide supplementary benefits once the NHI is fully implemented. So it will only cover benefits not covered by NHI. And I think this is an important point. And it's only when NHI is fully implemented. Now, we've spoken to various people in the industry, and unfortunately or fortunately, that's going to take between 10 and 15 years before the NHI is fully implemented. There is different challenges throughout the course, and I'll talk about that in a minute. So for the foreseeable future, the medical schemes as we know it now will stay as they are, and your benefit structures will stay as they are. The other alternative is, if you don't want to make use of the NHI providers, you can self-fund medical expenses. In other words, you basically go to a doctor who's not contracted, and you'll have to pay for it out of your own pocket if you don't want to use NHI providers, because your medical scheme will not be able to provide for a service that the NHI provides. And then ultimately, benefits covered by the NHI, that is really where you'll have to check what the referral system is by the NHI. So you won't be able to just go and visit a specialist contracted to the NHI. You'll first have to go to your local clinic, who will then refer you to the local GP, who will then refer you to the specialist. So it's on a referral basis that you'll then have to see these providers. You won't just be able to go and see a pediatrician if your child is sick, for argument's sake. You'll first have to go to the clinic will refer you to the GP, and if the GP is not sure, he or she will then refer you to a pediatrician for your baby. So what is the impact? The change from private healthcare to the NHI, the impact on private healthcare providers. Private hospitals and doctors will have to contract with the NHI, and that contracting period is going to take a long period of time as well. We must understand that all our private hospitals are either owned by shareholders or individuals, and they will want to still make profits. So ultimately, they'll have to contract with the NHI. And really, the NHI will also then determine where a specialist or a doctor must practice from. So if you look at your metropoles, where we've got an overpopulation of doctors, versus your rural areas where there's one doctor in every 100 square kilometers, they might require some of the doctors to relocate into rural areas, which is going to put pressure on the doctors as well. I think ultimately, also, as I said, that they could face huge losses if the NHI contracts at a lower rate than what they're currently earning in private healthcare environment. The impact on the members in the medical scheme. So members can either carry on their membership with the medical scheme while the NHI is in place, but if they want to use NHI providers, they will still have to have a strict referral process. And then also, members can decide to make use of the referral process or pay from their own pocket. So these costs may be funded by insurance or medical schemes only if it's complementary, not if it's the same benefits in the NHI benefit structure. So that is a big difference. Medical schemes will continue post full implementation of NHI, but not in the current format. And I think that is where the challenge comes as well, the implementation thereof. What does the implementation of the NHI look like? If we look at the implementation of the NHI, if you look at the right-hand column, you see there a minimum of 10 acts that are currently in place that will have to be amended. And the most comprehensive of those 10 medical scheme acts is the Medical Schemes Act of 1998. Because ultimately, that says what a medical scheme must pay, what it mustn't pay, what the providers need to fulfill. So each one of those acts could take a year or two, and many of them cannot be done at the same time. They have to follow on each other when you start doing the changes. So to change 10 acts could be anything up to 15 years. And that is, those acts will have to be changed before your NHI can be fully implemented. The other areas that need to be looked at is improvement of infrastructure. We know that the public hospitals are not fully functional at the moment. I mean, many public hospitals you have to take your own linen to at the moment if you go for a procedure. We know that basically the NHI funding model has not been defined. We're not sure how that funding is going to take place, and that is still one of the big grey areas in the NHI environment. And then they announced, the Minister of Health has announced that it can take 4 to 6 years to contract with providers. Doctors have to be contracted with, hospitals have to be contracted with, and those contracts are going to take a number of years before they can be finalized to start implementing. If we talk about the funding of NHI, as I said, there's an additional 200 billion needed to fund this program. Now, these are some of the stats that have been looked at by the Department of Finance. The Minister of Finance, in fact, did make an announcement in November last year that he did not think this is affordable. And I think that is the fact that we all know. Our country at the moment just can't afford to fund this in its full nature. So if you look at increases in VAT will have to increase from 15 to 21%, which you know is virtually impossible. You increase your income tax, personal income tax will have to increase to rates which exceed the highest in the world. I mean, we are one of the highest taxed countries in the world as it is, but if we have to increase that personal income tax, we'll take it through the roof. And then a payroll tax. Now, basically, this is for, excuse me, the formal sector. If anybody is formally employed, there might be an introduction of payroll tax. So ultimately, what could mean that you and I would pay more tax for less healthcare benefits if we want to basically retain our medical scheme and make use of the NHI. So those are some of the tax funding models that have been tabled by government to be considered. And we believe neither of those three are really viable at this moment in time, because the man in the street is already under financial pressure. And if any of those are increased, it could basically just put more and more people out of jobs. So, as I said, the big challenge is the constitutionality of the Act. So ultimately, as I said, the first area of the constitutionality will be challenged because of all the inputs that were basically not considered, and really the president just decided to sign the bill into law without any of the inputs that they received from private industry, from business South Africa, and from the different parties that have got an interest in the healthcare industry of South Africa. The next one is, as I said, according to Section 27 of the Constitution, is our existing rights to self-insure and to make sure that we are receiving what we used to. And then really also from a provider's perspective, the right to freely practice one's occupation, trade or profession. And this is where on the provider side, they potentially are going to challenge the Act and saying, well, I've got a right to operate in my occupation where and how I want to. And then really the rights of private sector patients and public sector patients, I think it's the right to basically choose, have a choice. And this is one of the suggestions that were made, is that we have a dual system. Yes, the private healthcare system is not operating efficiently. We know that the costs are going up higher, but ultimately proposals were put on that we have an effective private and public healthcare sector running side by side, that a person has a choice. If they can afford it, you can go to private healthcare. If you can't afford it, you make use of the public healthcare sector. So I think this is where the freedom is going to be challenged from a constitutional perspective. And this process, once again, if you speak to the legal fraternity, it's going to take something between 10 and 15 years for this to be challenged, and then outcomes being from the Constitutional Court. The next other is the other challenges that we do have is the funding. As I said, that is the big concern that we have. the funding that is necessary in a struggling economy. We know that currently our economy is growing at less than 1%, and ultimately the growth needs to come from within the economy. And if we're going to carry on putting on payroll taxes and employer taxes further, it's going to make companies struggle further and further. And also, second thing is we have a very small tax base, only approximately 7 million taxpayers in South Africa. And that is just the reverse of some of the countries where it's already struggling. If you look at the UK, where the national health insurance is struggling, and their tax base is approximately 80% of their population, where in ours it's less than 20% of our population are currently taxpayers. Then the other big challenge we know is the shortage of skilled healthcare professionals, where we don't have enough doctors and nurses to basically be able to offer a comprehensive service to the larger population. The change of the 10 acts that I mentioned, the court cases that are going to come from different providers, different organizations in South Africa, and then the contracting. So these are all different elements, the contracting with the different providers. And then we know, as I said, the hospitals and the doctors all also pay taxes now. And ultimately, if they remove the private healthcare industry and incorporate it into the public healthcare industry, there could be a loss of taxes being paid to SARS from these providers. And then further, loss of investment. I mean, if we look at some of the large hospital groups, they are continuously investing in enhancing their services and enhancing their hospitals. So that could come to a grinding halt as well, and which will result in a loss of growth in the economy at large. So, ladies and gentlemen, these are huge concerns and challenges that we believe will have an impact of the implementation of the NHI over the next 5 years plus. If I look at the unanswered questions, what medical service will be provided? In other words, what are the benefits? This has not been finalized, and this is the biggest challenge and concern to people. I mean, if I look at specifically amongst the ladies, I mean, we always know that when medical schemes introduce network options, and ladies always say, but if my gynecologist is not in the network, then I don't want to go to that network option. If you look at the next step here, if your gynecologist decides that he or she doesn't want to contract to the NHI, you might have to fund that out of your pocket if you want to stick to your preferred gynecologist. So these are small things that are huge in people's minds, and still there's no clarity. So this benefit structure will take months, if not years, to finalize. The funding, we've spoken about the different funding mechanisms. The funding hasn't been finalized. And ultimately, we know one thing is clear, that medical schemes will not be able to provide benefits that are provided by NHI. But until that stage, medical schemes don't know what they will be able to look at, and they don't know what their structures will look like. So that will put a further delay on the medical scheme structures post the full implementation of NHI. If I then look at the way forward, I think that is most probably an important point that we need to consider as well. What do we need to consider? And there's some myths or things to ponder around. When NHI law was signed into law, you obtain free healthcare cover at a private facility. Now, that is unfortunately what some people are being told at the moment. And that is the furthest from the truth. No public facility will allow anybody to walk in now and basically experience private healthcare, experience a procedure that the government will pay for. This is a long way off. So therefore, people must not cancel their medical aids. I think that is the most important message I want to bring across today. No cancellation of medical aids or gap cover or any form of primary care should be considered for the foreseeable future. It could take 10 to 20 years for NHI to replace medical schemes in the current structure. And post that, medical schemes will still carry on and offer insurance for supplementary benefits. I think ultimately the implementation of the NHI is dependent on, number one, government, and that we don't know the structure and the ruling party post next week, who will be in charge and what they will want to implement. So even that is a challenge that we have got to wait for an outcome of our election before we look at future funding allocations, ways of taxes. So those taxes I've mentioned now are just all speculation at the moment. None of them have actually been tabled for consideration. And if you look at what the other services that are all standing in line for funding out of our coffers, there are a number of them. We know that education needs money. We know that infrastructure needs development. Government debt is escalating at a rapid rate. And ultimately, government has got to start funding that as well. And ultimately, we see that in other areas. In education, the public sector education has got some good schools, but ultimately, to ensure enhanced education, you're still going to go to private education. If you look at security, police do a job, but more and more people are reliant on private security companies to doing jobs. So why are you allowed to have private education, private security, private electricity via your own systems in place, but they don't want to allow private medical schemes? So that is why we believe that there are going to be a number of challenges there to ensure that people will still have access to private healthcare going forward. And as I said, running side by side to the National Health Insurance Act. I think importantly, in conclusion, it's important for people to consider and not make hasty decisions. It's important that you retain your membership. And that's the single most important message I wanted to share today. I've had a number of people calling me since last Wednesday and saying, Gary, should I cancel my medical scheme? What must I do with my gap cover? And ultimately, people, please do not act hastily. Your medical scheme will be available and will operate in its current structure. Yes, we know that annually there are changes in benefits, slight changes, what's added, what's taken away. Your contributions will go up every year in line with inflation plus CPI plus medical inflation. But it's important that no person on private healthcare changes or cancels their medical scheme at the moment, because you will then have to self-fund your medical, or you will have to go to a state facility for any procedure or medication you do require. So I think ultimately the most important point here is the implementation of NHI will take time due to lack of resources, the lack of funding or funding mechanisms, and the lack of infrastructure. And those are the important messages that I wanted to share with you today. I think that is it from our side. I just wanted to give you a brief overview. I know we scheduled an hour, but as I said, there are a number of issues that still need finalization, and we are, by industry bodies, involved with this on a daily basis, and we will keep you informed as soon as we've got more detail around any of the benefits, the structures, the funding mechanisms, the potential taxes, both from an employer perspective and from a personal taxpayer. And also, I think a question that people have raised is, what's going to happen to my medical scheme tax credits? Now, if you look at what the tax credits mean to the government, we don't believe that they will necessarily remove that. They might see that as the first funding mechanism, but that will at earliest be removed in the budget speech of next February. If it does get removed, we're not sure it will be removed. It may be the same as this year, that it won't be increased by an inflation limit, but at least it will still remain, and that's what we anticipate that for the foreseeable future, because if people remove that, if the government removes the tax credit, the middle income class might be more under pressure, because on a family of four, your tax credit currently means a credit of approximately 1,100 Rand a month, which is about 14,000 Rand a year, which is going to just make private healthcare more and more unaffordable for individuals in South Africa. If you need any more information, please reach out to your NMG consultant, and they will be able to assist. We are putting together written communication as well, which will be a question and answer, and we'll take some of the questions received now. I'm just going to ask Karen to see if there are any questions that have been posed now that we could answer now. If your question is not answered now, we will definitely, as I said, put in a Q&A, which will be distributed to all our clients during the next couple of weeks as we get more and more information coming through. Karen, are there any questions?
Thanks, Gary. There are a few questions here. First one, what happens to our medical aid contributions? If we can't choose where to go and we must pay out of our pockets, why would we need medical aid?
I think it's an important question, Karen. And as I said, I mean, the medical aid contributions for the foreseeable future will stay in line with what they are now because your benefit structures will stay in line. As I said, in 10 or 15 years' time, when the NHI is fully implemented, and the Act doesn't even define fully implemented, but it's basically saying we believe it will take 15 years for all the elements to be addressed. So only once the Act is fully implemented, medical schemes will adjust their benefit structure because they won't be able to offer all the benefits. And then the contributions at that stage will be brought in line with the benefit structures. And probably in all likelihood, because it will only be certain benefits that are not covered by NHI, which will mean that your medical scheme contribution will be substantially less, depending on what the benefit structure looks like.
Thanks, Gary. What happens during the period before fully implemented?
Well, during the period fully implemented, I think it's important that people retain their medical scheme. And I mean, we'll stay in touch with all our clients and keep informed, but there's nothing for you to do other than retain your medical scheme, retain your gap cover. And if you're a primary care for your low income staff, retain that as well, because you don't want to let them or anybody experience a public healthcare facility at this moment in time. So there's nothing that will change from a medical scheme perspective for the next 10 to 15 years, if ever.
Perfect. Can one join an international medical aid that can effectively cover you as a foreigner?
Well, look, I think that will once again depend on what the outcome is. Look, I mean, anybody can always join international medical aid. International medical aids are incredibly expensive because, as you can understand, the term international means that you're covered across the world. And we know that if you do travel internationally and you want to take out comprehensive cover, it comes at a cost. So that is something that if you can afford it at that stage, as I said, you don't have to worry about that for the foreseeable future. But at the end of the day, as a South African citizen, we're not sure if you'll be obliged to use that and if you will be covered for private healthcare in South Africa with international cover post this 15-year period that we anticipate will take for the full implementation.
Given all the various challenges that were pointed out, which some seem to follow one another or each other, what do the experts believe is a realistic timeline for all of them to possibly be addressed?
Well, I think the realistic timeline, and I think the Minister of Health, as I said it's going to take 4 years to start the contracting process. So that's the first thing. So depending if they're going to start changing the Act in that 4-year period, or they're going to just focus on the contracting and what they're going to pay providers, and are providers going to be happy with that pay. So I believe that a minimum of 10 years is a realistic timeline. And it's not only my personal opinion. I've spoken to people in the medical scheme environment, providers of insurance. I've spoken to Business Unit South Africa, and everybody believes that 10 years is optimistic to say it will be implemented in 10 years' time. So I'm comfortable that for the foreseeable future, we as South Africans must basically just stay covered with your private medical aid.
Thank you. Does this mean that the private healthcare industry does not want to participate in NHI?
No, I think that's the furthest from the truth. And if you look at your 4 largest medical schemes, which would be Bonitas, Discovery, Momentum, and BestMed, all 4 of them, which I've engaged with personally, have done submissions and have offered to work with government. And I mean, if you just look at a scheme, the largest medical scheme, the open medical scheme, I'm talking about Discovery at the moment, which has approximately 3 million belly buttons, and that's dependents, so it's not principal members. So, and they employ 5,000 people to administer that scheme. So if you're looking at 3 million people get administered by 5,000 people, then if you're looking at covering 60 million people, you're looking at 100,000 people that the NHI will have to employ to administer this NHI scheme. So all those, and it's not only the 4 big ones, but all the medical schemes have offered to work with and work along, because they do believe that, and I think everybody, as I said in my opening statement, we all support universal healthcare, but they do believe with the experiences and the skills and the contracting methodologies they have, they can assist the NHI. So there's absolutely no intention of any private healthcare provider to work against the NHI.
Do you have a view on the probability of the legal challenges being successful?
Yes, absolutely. I think, and as I said, I've sat on some industry bodies who have engaged with some top healthcare legal people in South Africa, and there's absolutely belief that a lot of the challenges will be successful, and the government will have to back down on certain of these elements that they want to introduce, and ultimately there's a belief and that we'll still see a dual system being rolled out into the future, because the system that is on the table now via the Act is, as I said, not sustainable and is also not fully implementable as it stands. So yes, there are a number of those challenges that the legal people do believe will be successful and will basically result in changes in the Act.
It says here, hi Gary, in other words, private healthcare cover as we know it will not exist. And if it does, it will only be to cover a narrow list of treatments.
That is correct. I mean, and I think coming back to re-emphasize, it's only when it's fully implemented. And as I said, that cannot happen in a shorter period than 10 years. And after that, your medical schemes will be able to offer. So medical schemes will be available, medical insurance products will be available, but they will offer a narrow list of benefits which are supplementary to NHI. In other words, it won't be able to be the same benefits that NHI offers.
So it says here, so with the NHI coming to place, will I see my medical aid rate increase or decrease?
Well, I think your medical aid rate for the foreseeable future will remain in the bands that it's currently. As I said, will increase with inflation plus medical inflation. So it will CPI plus medical inflation, which we know, and we've communicated that on numerous occasions, that your medical inflation is approximately 3% higher than CPI. So your medical scheme increases are usually 3% higher than CPI. So for the foreseeable future, that's what the trend we foresee will carry on. And then once the benefit structure needs to be changed, then we'll see a substantial change in the contribution, which, if you think about it logically, will then be a reduction in contribution.
Were there pilot projects of the NHI done before?
There were, in fact, and it's a very good question. I mean, there were 11 pilot projects done across the country in different areas. And that's why there's a belief that a lot of the challenges will be successful. Those 11 projects were all failures to a lesser or a larger extent from the perspective of the costing versus the benefit structures. The resourcing just wasn't sufficient. And as I said, I mean, some of them were successful to an extent, but on a scale of 1 to 100, they all failed. Below 50%, they achieved on a mark when they were evaluated. And I've seen some of those results, and it was concerning. And hence we were surprised when the president insisted on signing this bill into law.
When will we start paying extra tax?
Well, that is a question that unfortunately I can't answer with certainty. I mean, we do believe that this is something that the government will have to start considering, because they've already appointed 40 or 50 staff members in the NHI office, which is chaired by Dr. Nicholas Christ. And they've got a salary bill to carry there already. So that salary bill will have to be funded from somewhere. So it will come out of the healthcare budget, but I mean, ultimately, we're not sure if it's going to be implemented next year, if there'll be some form of additional tax to fund NHI. That I unfortunately do not have an answer for at this stage.
Why would the president sign the act if government is not ready to implement NHI?
Look, I don't want to get involved in a political debate, but I mean, if you look at the last 4 or 5 elections, yeah, the last 4 elections specifically, NHI was put on the table every time, just the year before elections. And I think the elections coming up next week became a crisis that it's been mentioned on numerous previous occasions, and nothing was ever done to push it to the next level. And I think this is why he decided to do it now. And it was quite interesting when we presented to the provincial councils in December, Business Unit South Africa and myself and a couple of other people were chatting, and we said at that stage that if it's approved by the National Assembly and the government does sign it in, it won't happen long before the election, and that's why it happened literally 2 weeks before election, because people won't have enough time to actually analyze it in detail and then start saying, but this is smoke and mirrors. And please, I'm not saying for 1 minute this is smoke and mirrors, but it is a concern that it was signed in at such short notice before the election, not knowing that they will have a majority going into the next cabinet.
There is currently news that medical aids or the private sector is challenging the bill in court. Is there any chance that they will win and NHI will be cancelled?
Yeah, I think, as I said, I think it's very much along a previous question. I mean, it's private healthcare and I mean, even different unions and different organizations are challenging it, and it's not challenging the NHI or the universal healthcare. It's challenging the structure of the bill as it stands now. Nobody's denying that we want some form of universal healthcare. So if we talk about the challenges, it's around elements of the NHI Act as it stands now, rather than the concept of universal healthcare that's been challenged. And I think, yes, there are very good chances that those will be won. And as I said, I mean, I think it's not that anybody wants to see NHI fail, but they want to see NHI be successful in a structure and a format and a benefit structure specifically that is, number one, sustainable, and number two, can enhance the services that people are experiencing. I mean, if you look at the public healthcare environment now, that's probably a good place to start, is to enhance the servicing that people are experiencing in that environment.
Is medical insurance still allowed together with NHI, or will it also be restricted like medical aid schemes once NHI is implemented?
Well, that is not 100% certain as yet, but I mean, it just said that because the Medical Schemes Act is the act that rules the medical schemes, and that act has to be changed. The medical insurance products predominantly fall under Short-Term Insurance Act at the moment, and that the demarcation debate for medical insurance products was only been extended until March 2025. So in March 2025, these medical insurance products will have to be reviewed potentially as it is, if that demarcation regulation is changed at that stage already. So we're not sure what the impact will be post March 2025 for the insurance type products.
What about persons close to retirement? How will this new act affect those that will not have contributed towards NHI for an extended period of time and that are close to retirement age?
Well, I think. Look, I mean, it's the same as anybody else. What your tax position is will determine what you contribute. So if you're a retiree, a pensioner, and you do pay tax on your investment income or any other income you may have, there will still be tax payable. If it's a surcharge on your tax, if it's an increased VAT, you'll pay that. But ultimately, you'll have the same benefits no matter your age, and if you've paid towards it or not. Whatever you can pay, you can pay. I mean, there, as we said, there's approximately 80% of our population that are not contributing to any taxes at the moment, and they will receive the same benefits as those people who are paying 46% or 45% tax, depending on what it might be at that stage.
Do you believe that NHI is going to break the healthcare system in South Africa?
Well, I think that is a concern that the doctors' associations are raising. They are raising the concern that this uncertainty around the benefits and the funding and what they will be paid to operate under the NHI is resulting in immigration, and that is a big concern to us. And ultimately, so providers and doctors specifically are concerned about it and would potentially have an impact on the future sustainability of NHI. I mean, if you just think about it, and this is a discussion I had with some doctors' associations, the number of medical schools have not increased in the last 20 years, I think 30 years. So the same number of doctors are churned out every year as they were 30 years ago, and the population has doubled over the last 30 years. So the doctors that we're coming through the system are in real terms declining fast. And then we still see this unfortunate trend of immigration. And yes, so if the NHI is going to stay in its current format, it could potentially see the total demise of the healthcare structure as we know it.
Do we know if at this point those opposing the bill have legally filed their objections?
No, so yeah, so nobody has filed because only once it was signed by the president and it's gazetted in the act could they start putting together their legal cases. I do believe some people have been working on preparation thereof, but no legal cases have been actually submitted. As far as I know, I mean, this was as recently as Monday. Nobody had actually submitted any legal cases. I mean, I know legal firms have been engaged, and but nothing has been lodged at this moment in time as yet.
There are a few questions here that almost sound the same. Should we retain our medical aid? Can we use it together with NHI, or will they become obsolete?
Yeah, I think hopefully I did address that. I mean, so your medical aid is absolutely, I mean, as I said, my most important message to everybody today is to retain your current medical aid. Nothing will be changing on that for the foreseeable future. When I say medical scheme will not become obsolete, it will be the structure and the benefit structure will change, but will not be obsolete. And I think it's important that people, and we will, as consultants, will stay in touch with all our clients and basically guide you through this process when it does happen one day, to say what medical scheme, what the NHI offers versus what we believe you need to take as a supplementary cover.
And the last question is what will happen to our medical savings accounts? Are there tax implications on the cash? And can we cash it out at the end of the year?
Well, you can't cash out your medical savings accounts ever unless you either leave that medical scheme, you resign from the medical scheme, or if you're on a medical scheme and you go to an option on that medical scheme which does not have a medical savings account, because there are some hospital plans, for argument's sake, or some network plans that don't have medical savings accounts. So you go to one of those options. 5 months later, your MSA, your medical savings account, will be paid out to you in cash. And ultimately, look, I mean, there's no tax implications on that because that's paid with after-tax money that you've paid that contribution or that contribution to the MSA. But and the reason why it's 5 months is you can submit a claim to a medical scheme for 3 months after the procedure. And after 3 months, that claim becomes stale. And therefore, it still gives the medical scheme another month to process that claim. And then in the 5th month, at the end of the 5th month, traditionally, the medical scheme will pay out your medical savings account to you. But as I said, that's only in case in two options: when you resign from a medical scheme or you go to an option on your current medical scheme that doesn't have that. So resignation to me at this moment in time is not an option. When should the medical scheme act change, and in 10 or 15 years' time, when NHI is fully implemented, those medical scheme savings accounts balances will be paid out to you, to the members in full. That's your money, and you're entitled to that.
We actually have a couple more. With the NHI contracting service suppliers, Will this not ultimately lead to the government fixing prices in the long run?
Yeah, I think that's one of the challenges that has been brought around the NHI, because the NHI, as the bill stands now, the Act says it's a single funding model. So, and that is where some of the provinces, and specifically the Western Cape, raised it to saying that they want it basically at a provincial level, because each province must take responsibility for the budget and for the management of their service providers in their province. So the single funding model and the single contracting model is one of the concerns that have been raised around the NHI, because ultimately the people at ground level will have no input or control over what the service levels that they receive and who they can contract. So absolutely, that is one of the issues that has been and will be challenged around this. It was challenged during the consultation process, and that's why, once again, your constitution has been compromised, because some valid concerns were raised, were just totally ignored.
Another one here. What does the NHI mean for pharmacies? Do you think they will continue as usual?
Well, no, I think pharmacies, as a service provider, they'll be contracted with the NHI. I mean, we know currently medical schemes contract with pharmacies to be what they call designated service providers. And ultimately, the NHI will have designated service providers to distribute medication as well. So that is one of the service providers in the agreement that will have to be contracted under the NHI.
What will happen to gap cover? Will this be necessary going forward?
Well, that's also an interesting question. As I said upfront, is don't look at cancelling medical scheme gap cover, or if you have a healthcare insurance product at the moment. But the role of gap cover could basically form part of your supplementary cover post the full implementation. But once again, we're not exactly sure what the benefit structure is going to look like. Look, the role of gap cover at the moment makes provision for the shortfall between what the service provider charges in hospital versus what the medical scheme rate is, and what the medical scheme pays. So if you just look at it from a layman's terms perspective, there shouldn't be a shortfall, because if you use an NHI provider, a contracted NHI provider, then you shouldn't have a shortfall, and you could only have the supplementary procedures or benefits that are not covered by NHI, which the provider will be covered by a medical scheme benefit, and depends on what that benefit structure looks like. So for me to say that gap cover is going to be around or not is difficult to say, but ultimately it is a form of insurance which potentially could offer supplementary benefits post NHI full implementation.
I think this may be the last question. Will private hospitals become public hospitals?
Well, yeah, look, I mean, the terminology, yes, it won't be a public hospital, it will be an NHI service provider. So it will basically be it will be a contracted hospital to the NHI, which basically would be the same as a public hospital, because everybody will have the right to go there and have the right to be treated there. So ultimately, yes, it will be deemed a public hospital, but it will be an NHI hospital. I think the important point is we will see. So you won't be able to just run to hospital now, like we sometimes see people do. Is, as I mentioned, you'll have your almost a triage system, or a basically a referral system, where you'll have to go to your local public clinic. You'll see a local nurse who will then basically evaluate your condition. If he or she can't, with surety, saying, well, this is the problem you have, they'll refer you to a local GP who will look after 2 or 3 of these local clinics, and then he or she will basically evaluate your condition. And if they believe that you need to see a specialist, they'll refer you to a specialist, be it a physician, be it a gynecologist, be it a pulmonologist, whatever the condition may be. But you won't be able to go directly to those providers in the NHI environment.
Sorry, there's one last one. So we might start paying extra tax or VAT for this soon, but need to keep our gap in medical aid and only be able to benefit from NHI in 10 to 20 years.
Yeah, I think that's the unfortunate reality. And as I said, I mean, it's going to put pressure on people, and you will unfortunately see people that cannot afford, if the taxes are increased, afford the increased tax contributions that they pay, because it will be deducted from your salary, and still retain the medical scheme membership. But before you cancel the membership, I think we're there to help you look at, I mean, it's not cheaper, I mean, but lesser versions, so that at least you got access to private hospitals going forward until the full implementation. So yeah, that is a concern that we have, is that if the government are going to start increasing taxes, introducing new taxes, then it is going to put more and more pressure on people's financial situation going forward.
Thanks very much, Gary.
All right.
That's all for now.
Thanks, Warren. Ladies and gentlemen, thanks very much. As I did say earlier on, hopefully you find some use and value in the session. Please, if there are any more questions you have, raise them with your NMG consultant, email us, and we will respond to you. We are going to take these questions and try and group them together and put a Q&A together that we can distribute, that people can basically refer to and share with colleagues and friends regarding the NHI. Thank you very much for your time this morning, and all the best, and stay safe and just look after your health. That's the most important. Keep well, everybody. Bye-bye.